run a joint adolescent teenage diabetes clinic.
We've had quite considerable difficulty ensuring that the young people actually get to clinic on a regular basis. One of the things that we've been exploring is what it might be that puts them off.
We could have done little questionnaires with tick boxes, but we just knew that our patients probably weren't going to fill it in.
We were obviously conscious of Big Brother on the television and lots of young people are watching that, so we thought we'd try and borrow that idea.
Sit in the diary room, tell us a bit about themselves, tell us a bit about what they enjoyed about the service, what they didn't like about it.
It just helps me to keep on track with my diabetes and gives me advice.
And what I'm worried about going to the next clinic is
one of the biggest things that came back was that concern about moving from a teenage adolescent service into the adult service.
We've tried to make some changes already, so we've had the development of this young people's area, teenage area in the outpatients clinic.
Everything we do has got to be centred around the patient. You know, if it's good for the patient and they feel better about it, they'll manage their diabetes so much better.
The need was prompted by a review of the ward accommodation driven by the Privacy and Dignity and Same-Sex Initiative. The solution that we looked at other hospitals was to create a toilet and shower in every bed bay, but that would mean losing one bed in a bay of 6. So over the project we would lose a whole ward's worth of beds and we couldn't afford to do that. So we looked a little bit more laterally and came up with the solution of building them outside the ward and then create a small corridor link. The team involved patient representatives who helped us with the initial review of existing facilities.
And to comment on the appropriateness from a disabled point of view.
So the key things we wanted to look at were grab rails,
the height of sinks, sockets, toilet rolls, shaver points for example. And we had to try and get all of that into a small space.
It's made such a difference. I mean, before we had 4 toilets, we're 10 now, which is just fantastic.
And the end result is that patients are very happy and in fact talking to them they say they're better than the facilities they've got at home.
We do get patients coming to hospital, elderly patients that are already malnourished, and it's really a challenge to get them to eat and drink. And what became apparent through observation at mealtimes, that even with everybody stopping to help patients, there still wasn't enough staff around to deal with the more challenging patients. I was given funding for 9 months to put people in place. We only put them on 2 wards and we used a comparison ward as well.
We're a front line to assist with the more complex of the feeds, those patients that possibly aren't able to feed themselves or need a little bit of encouragement, a little bit of assistance. But there's also the personal side of things.
Have a little drink for me. All right.
The more you can get them to trust you, the more they're likely to drink for you, to have to eat for you.
The teams, there's 10 of them in total delivering that service to patients, and we've rolled them out onto 5 wards now. If somebody's well nourished and well hydrated, they're going to improve quicker.
So that's the satisfying thing, watching people leave after you've had some input with them.